just move on because we have some time shortage. So next we have Professor PARIJAT Chandra. He's going to talk about ROP surgery, indications, complications, role of anti-VEGFs, and bilateral ROP surgery.
So, good morning. Thank you, Professor Atul Kumar, for making me part of this course, and it's always a pleasure to speak in front of Professor Dogra, who's already a master of ROP, and I learned a lot from him and my co-instructors as well. So I'll be talking about ROP surgery. So we understand that ROP surgery is a challenging situation, and you need an expert anesthesia team, you need an expert neonatology team to take care of the baby so that they come out of surgery safely. So how are the results of stage 4 ROP? So this is a case which you see here is having a detachment happening in the nasal retina. It's in stage 4A, and if you operate this eye, this is what it comes like at 4 weeks. So you understand that if you do a good ROP surgery, the traction will go away and the retina will attach again. So when should you operate? Let's see this case. So this case, you can see both eyes, the retina is detaching, and it's in 4A. In the right photograph, you can also see that the hemorrhage is happening there, and child was advised surgery. However, the child got sick and could not be operated, and when he came back to us 10 to 14 days later, this is what it looks like. So you see the prognosis has worsened a lot in the next 2 weeks, and now you can see that it's gone into stage 4B. The macula is also detached and dragged. So what I'm just trying to show here is that we should not delay ROP surgery. If you delay ROP surgery, the ridge will pick up more height. It will become more peripheral, more vascular, making instrument access difficult, and also making the surgery outcomes poor. And as the retina continues to rise in the center, the lens might get involved, lens sparing surgery might not be possible, and if the macula gets involved, the visual prognosis might deteriorate. So this is not the time to refer a case for stage 4 ROP surgery, because this is all too late. It's very difficult to do lens sparing, and even if you do something, nothing much is going to come out of it. This is the time when you want to refer a case for stage 4 surgery, when the detachment has just started, you've already possibly done laser injection, something like that, and the retinas continue to progress despite treatment, or you get a primary case where the retina is detaching, then you want to do this. So let me show you one of a few cases. So here you can see it's in zone 1, and you can see it's detaching here. So this is just to show you the surgery of this case. So it's 25G lens sparing vitrectomy, which is being done here. You can see the central TRD is there. The traction is being relieved by the cutter in this eye. And there you can see the fresh laser marks are there, given just before starting the surgery with LIO. And you can see the yellow vitreous is there. It's all gone now, and you can see the reddish glow coming after the yellow vitreous has gone, and here localized PVD is being done. And you can see the posterior pole is also not well vascularized, and this is what it comes out at 4 weeks. So again, this was a late case to operate, and this outcome might not have been possible, but it did do well. So what are the basic principles which you want to look out for? So this is just to show you a pre-op photograph. I'll show you the case after this. So basically you want to deal with this kind of central traction which is tending to pull the ridge towards the disc. You want to deal with the vertical traction which is causing a TRD and pulling it towards the lens. And you want to deal with the circumferential traction which is contracting this ridge and making it go. So this is another case which you can see now, same case which I showed you the photograph. So here now we're dealing with the central traction and removing the band which is tending to form here and trying to pull this retina towards the disc. Now the vertical traction is being dealt with so that this traction can fall back. So these are basically new vessels growing into the vitreous which are pulling the retina. So that's why they tend to bleed. And this is the circumferential retina traction which you see there. So the vessels are now being dithermized so that they don't bleed post-operatively. And the traction has been relieved there and all around. And you can see the vertical traction is also gone. The circumferential is also gone. And this is the end of the cleanup. So another case here you can see is a heavily lasered aggressive ROP, and you can see the arrows indicate where a traction is developing and pulling this membrane over the whatever small retina is left. So in these cases we like to do 27 gauge vitrectomy because it allows us to do this without much manipulation and without much instrument bending. So you can see here the traction is being relieved. This sheet of vitreous which is pulling it towards the TRD is being removed so that this retina can fall back, and obviously you can see that the retina is already having a fold and is pulled there, and it's a very small retina because most of it has been lasered. So what do you do when you get a case like this? Here you can see that it's already lasered, is going into stage 4A. detachment is happening, and it's got extensive neovascularization. So if you do surgery in these cases alone, then again, there's a high chance you'll have intraoperative bleeding, postoperative bleeding, and it will still continue to contract and progress. However, if you combine this with anti-VEGF injections, then in the same setting, intraoperatively at the end in an air, you can inject half dose Lucentis or Avastin, whatever you want. And this is the kind of outcome which you will get only if you combine anti-VEGF with surgical intervention. Otherwise, this kind of outcomes are not possible alone with surgery. Since most of these cases come with 4A bilaterally, it becomes difficult to deal with one eye and leave the other eye alone, because the other eye might worsen and the child might be sick enough and might not be cleared for the second eye surgery. So we like to do it both eyes in the same setting, which allows timely management and allows a single exposure of GA. But obviously you have to treat it like a 2-eye procedure, so second eye has to be treated like an independent surgery. The team has to re-scrub between, we change the instrument, change the fluids, put separate post-op drops, and obviously parents have to know why you are doing this kind of procedure. What is the urgency of operating both eyes together, just in case an infection or something happens, a problem happens. So just to inform you of some common complications which newcomers might have, or even expert people might also have. So here, because the eyes are small, the instrument go and hit the retina, a small break has happened there in an attached retina. So you just go ahead and laser and you can deal with the problem. Sometimes when there's a high TRD which is there, then even instrument entry can lead to a break. So these kind of complications have to be avoided. Otherwise, the surgery becomes very difficult in these cases. Iatrogenic lens touch is a common problem which can happen because it's a very small eye and the cannula is constantly moving as you try to do vitrectomy in different parts, and the lens can be touched by the cannula. But unless it's a very big posterior tear which leads to hydration of the retina, the small indents can be left as it is without doing lensectomy, and the localized cataract stays in the periphery which needs no further intervention. This is a more alarming kind of situation which happens again because of the misdirection of the cannula, again because of the small eye. So if you take care that the cannula doesn't misdirect during surgery as you're trying to do peripheral manipulations. And even if it does happen, then nothing needs to be done. You just need to let the fluid come out through the ports and ensure that you move the cannula to another port so that the pressure is maintained inside and the fluid does come out and the eye can settle back. Obviously, post-op bleed is the most common complication which happens in these cases, as you are cutting a lot of new vessels which are going into the vitreous and doing a lot of manipulation. So never leave bleeders. I think that is the main thing. Don't leave bleeders alone and pray that they'll stop on their own. They won't stop. They'll continue to bleed once the IOP falls and the positive pressure of the VEGF goes away. So it's important to control all the bleeding before you close the surgery. Stage 4 ROP, unfortunately, is a very sad situation in our country. We get around 10 cases every week coming now to RP center, and the number is just going on increasing every year. Unfortunately, these babies are blind, but surgical results are also poor, and trial is given in the hope to get some kind of navigable vision. The recent ICROP divided stage 5 into 3 parts. Stage 5A is when the disc is visible. Most probably we leave these cases alone if you can't do anything better than this. Stage 5B are the ones we most commonly operate. Stage 5C depends. If the anterior segment is very bad, then possibly you might leave it. Otherwise, it's just like stage 5B itself. So just to show you a case how I like to do it. So this is a hybrid vitrectomy. So basically these are 23G MVRs which go in, through which 25G instruments go in. This allows for a snug fit as well as instrument maneuverability. It's a clear corneal approach. And you can see that now the pupillary membranes and the synechiae and the lens has been removed, and now this is a dense retrolental membrane which is there. So the idea is to remove this retrolental membrane so that you can get access to the posterior retina and then go ahead and manipulate it to release whatever is contracted behind it. So once you create an opening in the clear area of the retrolental membrane, then you can do binaural dissection, you can use scissors and forceps, you can continue with the cutter. And as you continue to dissect into the periphery, the retina will continue to fall back and the funnel will continue to open. So this is an open funnel configuration, as you can see. There's not much contraction behind, it's mostly tissues which are there. So as you continue to cut these tissues and remove these tissues, the retina keeps on opening up into the posterior part of the retina. And this is the last bit of tissue. Once you see this is gone, then you see there is the disc and there is the attached posterior pole. So these babies are basically left for blind, and basically a trial of surgery can be given, because if you are able to get something like this, then the child will be able to have some kind of thing. And you ensure a sutureless closure, air is injected in the end, and this is how it looks like at the end of surgery. So I'm not trying to say that these outcomes are very good. The outcomes are universally very poor in stage 5 ROP. What I'm just trying to say is that you can give a trial for surgery in these eyes, and if the funnel does open up and if there is a good macula sitting behind, then possibly the child will get some kind of navigable vision which will change the life, not only of the child, but of the family as a whole. Thank you so much.
Thank you very much, Dr. Parijat, for excellent surgical videos as well as showing all aspects what we need to do in cases of retinopathy of prematurity. And what has come as a boon, and you have really emphasized that if we do early lens-sparing vitrectomy, and you talked about bilateral sequential, I think that is what is very important, because these are the cases, they'll progress very fast. And if we can do timely lens-sparing vitrectomy and sequential, and we don't sort of wait till they go to stage 5, where you have already shown is a challenge, and mostly the prognosis would be poor, and you have shown beautifully so many well-managed lens-sparing vitrectomy cases, which I am sure their visual gain is very good. I think that is what we